Hello, everyone, and welcome. We're delighted to have you join today ADAA professional webinar, Prolonged Grief Disorder and its Treatment. We have Dr. Shear with us today to help lead this program. Before we get started, I do want to go over just a few details for our live audience. This webinar is being recorded and will be available on demand. Closed captioning and translation are available through Zoom, so if you would like to take advantage of that, you may turn it on in your Zoom features. And for those who have applied for CE credit, you will receive a link with instructions at the end of this webinar. We welcome you to submit your questions at any time in the Q&A feature. We will be having a dedicated Q&A portion at the end of the session. I would like to introduce our presenter, Dr. Catherine Shear, who is a Marian E. Kentworthy Professor of Psychiatry and the founding director of the Center for Prolonged Grief at Columbia University School of Social Work. She is a clinical researcher who has first worked in anxiety and depression. For the past 25 years, she has focused on understanding and treating people who experience persistent intense grief, which is now an official diagnosis called prolonged grief disorder in the ICD-11 and the DSM-5. She is widely recognized for her work in bereavement, including research and clinical awards. Her work includes more than 330 peer-reviewed publications, which is quite a lot. So I would like to just hand it over to you, Dr. Shear. Thank you so much for joining us today.
And thank you, Sasha, and thanks to everyone who's here. And let me go ahead and share my screen. And it's a pleasure to.
Oh, you are muted, Dr. Shear. Dr. Shear.
Yep. I
There you
got
go.
it. I just said that it's a pleasure to be here today. And thank you, Sasha. And also to have been awarded a PhD by the ADAA, which I don't have, but I do have an MD.
Oh, so sorry.
That's okay. Yeah, so we're going to talk, as you know, about prolonged grief disorder and basically, hopefully, how to recognize it, understand, and treat it. So, first of all, I want to just introduce the DSM-5 and ICD-11 official diagnoses, and then talk a little bit about a way to understand them, to understand what's happening, and then get into just a big picture, brief overview of the treatment, what we do, how we do it, why we do it, and a little bit about our outcomes. And then hopefully we will still have time to have some Q&A. So the first thing we want to talk about is what is it? And this, as you know, I'm sure you know, is a brand new diagnosis. It was first put into the official diagnostic nomenclature by the World Health Organization in 2019, using what they did for all of ICD-11, a guideline as opposed to actual criteria, although I did model this a little bit after them in terms of how I'm presenting it right now. The DSM criteria are specific criteria, as always. So for the DSM-5, we have to have at least 3 of a set of 8 criteria that are listed here, summarized here. And for the ICD-11, it has to be at least 6 months after the loss, whereas for the DSM-5, it's at least 12 months. And the ICD-11 provides guidelines sort of such as, so it's and for both of them, we have to have experienced the death of someone close, and there has to be persistent, intense yearning, longing, or preoccupation with the person who died. And there has to be significant distress or impairment in important areas of functioning, and the duration and severity of this condition has to exceed expectations of the social, cultural, or religious group that the person belongs to. Actually, that is an important distinction, but in actual fact, it's mostly on the shorter side that those differ. So it's very unusual for a culture or social group to expect longer than a year, for sure. but that is a part of the criteria, and it certainly is important um, to consider social and cultural factors in grief, which we'll be talking about a little bit in a minute. So it's also probably helpful to know how prolonged grief differs from depression, because that's the condition that most people confuse it with. In fact, when this, you may be aware that when this diagnosis was made public, which was really it was just a little bit over a year ago, in March of 2022, there was a New York Times article announcing the inclusion of prolonged grief disorder in the DSM-5, and it was a very negative article about this and about its inclusion, and there was a lot of public response, not surprisingly, I think, supporting the New York Times position that this was kind of an egregious thing. Among those, the people who responded was Benjamin Sadak, who's a very well-known and really prominent psychiatrist, who said also that this was not a needed diagnosis because grief either resolved on its own or it became a depression, and we knew how to treat depression. That actually turns out to be an erroneous statement, and there's a lot of literature about this. So this slide really summarizes what those differences are. And what's not on the slide, which is maybe even more important, is that grief simply doesn't respond to really good treatment for depression. And I'll show you that at the end of this presentation. It's really how I got involved in doing these studies, which was because I was working with depression researchers who were already trying to use antidepressant medication and also interpersonal psychotherapy, and neither was helping prolonged grief. And it's also different from post-traumatic stress disorder, although in some ways it's more similar to to post-traumatic stress disorder. But the focus, of course, in prolonged grief is dealing with the permanent absence of someone close. So it's really dealing with that permanent absence, which has a lot of important ramifications. Whereas for the most part, the fear in the focus in PTSD is, of course, on fear of recurrence or fear of further serious injury, death, or sexual violence. The primary emotions are quite different in grief, as we just saw. It's yearning, longing, and preoccupation with the person who died are really the central focus of the emotion, whereas in PTSD, it's fear and anxiety. Both have associated other symptoms, but the central focus is quite different. And similarly, the thoughts are person-related in PGD. The avoidance is related to loss cues, and it's kind of and or fear of grief activation. And those cues are reminders of the absence of that person. And they tend to be quite pervasive, and their result is to activate grief. And whereas the cues are reminders in PTSD, of course, are reminders of the danger, they're linked much more so to the event. They tend to be more limited, not really as pervasive, and they activate fear or anxiety. And nightmares are actually quite rare in prolonged grief disorder. And we do think that there's pretty good evidence that the reward system is centrally involved in PGD, and probably more so the fear system in PTSD. And then this is a summary of the differences from usual continuing grief. And so what the New York Times article said in 2022 was that psychiatrists had decided how long people should grieve. And that was a complete misstatement of what this is about. No one is saying that grief ends. We know perfectly well that grief doesn't end. Any of us who's lost someone close doesn't stop feeling some degree of yearning and longing for them, or at least missing them, something on that spectrum. And that can actually, in certain situations, that can be intense at times. It can be intense, especially at certain times of the year, the anniversary of the death, family holidays, things like that. And sometimes life events, someone graduates from school, from some kind of school, or a baby is born, or somebody gets married. Those kinds of events can also often activate grief after someone close has died. And and in addition to the fact that the yearning and longing, which may be present, is more intermittent, even if it's intense, it's definitely intermittent. So are the other symptoms. Those other symptoms that are listed in the DSM are pretty prevalent, pretty much occur to some degree with almost anyone in the early period of grief, which we call acute grief. And they can persist. Some of this can persist intermittently, again, for quite a long time, maybe even throughout a person's life, but they're not, the difference is that in PGD, these symptoms, at least 3 of them officially in the DSM, but in the ICD, some of them are, again, persistent and intense. And that's really related to what John Bowlby called defensive avoidance, which is this whole set of ways of coping with acute grief, with the loss initially, which can be quite helpful, maybe even necessary, in order to be able to move forward, because the emotions, grief is an incredibly powerful experience, especially when it occurs with an unusually or an especially difficult loss. But we have to, and we can't just grieve and grieve and grieve. We can't just be present in the grief all day long, every day. So we need to be able to set it aside, and using a variety of ways of doing that. We'll talk about this a little bit more later, but is a natural thing, and it's helpful. But when it persists and it continues to play an important role in coping, it becomes problematic. And then also a big difference is that prolonged grief disorder makes it really difficult to engage in ongoing life, and people don't make progress in accepting the reality that they're in accepting the fact that the person is really gone and not coming back, and or in restoring their own capacity for well-being. Whereas with usual continuing grief, those things do happen. So just to summarize that, for most people, grief is never completed. However, usual continuing grief is much less intense, it's much less pervasive, and it doesn't really interfere with life, ongoing life. In fact, it can sometimes be helpful. So let's back up a minute and just talk about grief itself. It's a complex, multifaceted response to loss. It's a natural response to loss with psychological, physiological, and social aspects that are unique to each person and each loss. So even one person doesn't grieve every loss in the same way, and 2 people don't grieve the same loss in the same way either. So that leads a lot of grievers and grief people in the grief community, I would say, to say that grief is unique to every person. and it's also interesting because it will show up in different ways at different times, related to things like what it means, when and how it's activated, things like that. So the lived experience of acute grief tends to be strong emotions, insistent thoughts, often social and spiritual behaviors change, responses change. There are physiologic symptoms, and grief-related behaviors often are pretty prominent in a person's life. And then we have these also very commonly defensive coping strategies, the disbelief that's pretty much automatic, protest, which is very, very common, emotional numbing, not uncommon, the tendency to counterfactual thinking, imagining alternative scenarios, is pretty much universal to some degree, maybe more or less prominent. What we call caregiver self-blame or anger, trying to avoid the reminders of the loss, is, again, people don't go out and go to their favorite restaurant that they went to with that they used to go all the time with the person who died, right after the person, when they're experiencing acute grief for the most part. Um, and often people also try to avoid the kind of confrontation with the loss by trying to stay close to the person by seeking sensory experiences. It's a kind of interesting thing by listening to their voice on an answering machine, looking at pictures, of course, even smelling their clothes, or occasionally touching themselves. We had one person who would touch her forehead because her mother died, and she was trying to recreate the feeling of being with her mother. Um, but then as we start to accept the reality and restore the capacity to thrive, which is really what we mean by learning to live with the loss, grief, our experience of the loss changes, and that transforms grief, and and sort of helps it find a place in our life, so to speak, and so that's how basically acute grief is gradually kind of transformed or evolves into what we call sometimes integrated grief. But even when it gets there and it's kind of found a place in our life, grief doesn't always stay quiet, as I was saying before. And it's important to recognize that, because sometimes people interpret those periods of activation of grief as being quote unquote unresolved grief, and that it somehow means that there's something that you haven't done properly or experience, you haven't really coped with the loss in the proper way or something like that, which is not true necessarily. So let's back up and say, I can explain a little bit about why I say that, because I think we need to kind of understand what's happening when we grieve. Where does grief come from anyway? We know we all grieve when we lose someone close, but why do we grieve? And I think one way of understanding it, and I think pretty good way of understanding it, is to turn to attachment theory, because we really want to understand what it means to have someone close in our life. And this is a good way to sort of, at least in general, from a high level of abstraction, kind of understand what it means when we lose someone close. And as you know, we're biologically motivated to seek, form, and maintain close relationships with a small number of people in our lives. There's a lot of really good empirical support for that. And um, and that and once that relationship is formed, we find the person to be generally rewarding to be with, and we resist separation from them. And what that's in part because they provide us with a very good source of comfort and support and help when, all kinds of instrumental help and emotional help when things aren't going well. We call that their safe haven function. And they also are people that have faith in us, basically, and they tend to encourage us to go out in the world and learn new things and take risks and do things and perform in the world. And so that's also very, very valuable. Actually, there's research showing that that function is even more important, especially for adults, than the safe haven function, though both of them, of course, have a role in our lives. And there's also interesting information that these our close relationships mediate, largely mediate our feelings of belonging and mattering in the world more generally, which is one of the what are called self-determination goals that we need in order to have a sense of well-being and to thrive in the world. And then it turns out, in addition, our close relationships can co-regulate many aspects of our functioning. This is there's a whole body of research. Each one of these sort of functions listed on this slide have some evidence that that the attachment working model affects the regulation of each of these different functions. So this is all, most of it is out of our awareness. Some of it is in our awareness, but a lot of it is out of our awareness. So really, our close relationships are affecting us even when we don't know they're affecting us. We know they're very important, but they also have these other effects on our body and mind. And in addition to sort of the attachment relationships, which are the people, our attachment relationships are the people who provide us with the safe haven and secure base and the feelings of belonging and mattering. We also do that for the people that we love, the people that we're close to. So we do that through what's thought to be a separate sort of caregiving system. It's the mirror image in a way of attachment. And it's also quite important to us. It's definitely important to adults. I hang out these days with a lot of little kids, and they are clearly, to me, they clearly are very interested in caregiving also when they see something, especially caregiving their parents when their parents aren't totally on an even keel. But that's just kind of an aside. But caregiving is very important to adults, and maybe even more important than feeling that they have a person that they can rely on or we can rely on. And it's a little bit of a Sophie's choice. It's not really either or, but it is quite important, and it's often not talked about, which is why I'm emphasizing it. And then the other system that I think is clearly important in grief is the exploratory system, which is that sort of inborn natural motivation to learn and grow, to to explore the world in order to learn and grow. Again, very important to our sense of well-being. And when our attachment relationships are threatened, this deactivates exploration. And this is really what we see, actually, this is all what we see in grief. Is it can be largely explained. A lot of the sort of commonalities in grief can be largely explained by what we pretty much know to happen when we're meaningfully separated from a person, an attachment figure or caregiving recipient. Those systems are said to be activated, and when they're activated, they lead to proximity seeking, and they lead to a certain amount of separation, anxiety, guilt, anger, and probably there is some evidence also for dysregulation of those systems that I showed you a few slides ago that are also affected by our close relationships. And then also we have the inhibition of the exploratory system, and that leads to, the proximity seeking, yearning, longing, and preoccupation is really a form of proximity seeking, right? And then typically we have anger, anxiety, guilt, physiologic dysregulation are associated, are hallmarks of acute grief also, as is a feeling kind of lost, like not knowing really, feeling almost like you don't know who you are without this person. That can happen. A loss of sort of loss of sense of competence in the world, and a loss of motivation to really be interested in anything or do anything except that, something related to the person who died. So this is one of the reasons that we say that grief is the form that love takes when someone we love dies. So that's another interesting kind of unique thing about grief, is that it is much more of a mixed bag for people than, say, typical anxiety is, or depression, or the other symptoms that we tend to treat, the other conditions that we treat. So in addition to being maybe a form of love, which I really think it is, loss of someone close is also, we know this for sure, one of life's most difficult stressors. And that's because the absence of a person we love, of course, in and of itself, all by itself, is very, very stressful, but it's almost always associated with a lot of other stresses. Some of which are listed here, some of the more common ones, like intense emotional loneliness accompanies that. Changed responsibilities are often present. Sometimes there are things we have to do that we didn't do before, and sometimes there's if someone's been ill for a while, um, or if it's a child who dies, then we all of a sudden don't have responsibilities, and that can be stressful too. And then we often have a loss of a sense of self because the person, we're very intertwined, naturally intertwined. Our sense of identity and our sense of self is intertwined with the people we're close to. Feelings of belonging and mattering, as I said, uncontrollable emotionality is very typical of acute grief, and that can be quite stressful in and of itself. Family dynamics often change, and not infrequently there's people around us don't know what to say, and or sometimes people have a sort of feeling that they don't want to, that there's a sort of contagiousness of loss, and so there can be feelings of exclusion. There can actually also be actual exclusion from social groups. And just one more comment about grief itself being stressful. It's such a powerful and complex response that typically has confusing thoughts and mixed feelings, some of which are listed here again. That is also a stressful situation. It's both the power of it, but also the way that we want it to go away, and we also want to hold on to it. And we want to be free of pain. It's sort of part of holding on to it, but the grief going away. But it's also the idea that we should be in pain because because almost to out of respect or something to the person who died. We want to move on, but at the same time, we don't want to. We want to, want other people around, but we find it hard to connect to them. So all of these things can be stressful also. So coping is, of course, the way we deal with stress. And in the grief field, we tend to talk about loss-focused coping and restoration-focused coping since 1999, when Maggie Strobe and Hank Shute um, published a quite influential paper called The Dual Process Model of Bereavement, Coping with Bereavement. And I think it's a very, very useful way to think about this. So if we think about the loss focus is going to be, of course, what it sounds like, that, sort of coming to grips with the fact that that person is gone. And we tend to use avoidant coping, but of course we can use avoidant coping to kind of keep that at bay, and that can be important. That we'll again get back to in a minute. And then, of course, changing how we think about it. We obviously can't change the stressor in this case, but we can change how we think about it. We maybe can change some of the associated stressors. And then the restoration focus has to do with how we're going to move forward in our own lives. So we have to cope with all of that. But we kind of started thinking, when I started thinking about this, and actually I learned this I have some interest in environmental issues, and this comes from the environmental literature, actually, that they point out how adapting and coping can be seen differently. And I know we often use them kind of interchangeably, but I'm going to suggest that we can, in this field, we like to use them separately. Because adapting is really the way that we adjust to change, and it's much more long term and ongoing. I mean, we're constantly adapting to all different things. It's kind of what living things do. And it's basically a process that tends to build new resources. I think the images here really show you the differences, I think, most clearly, but that's compared to coping, which tends to be more short-term and time-limited, focused on a specific stress or stressor until that's either removed or managed. And it tends to use resources as opposed to build new ones. So in other words, we need to adapt by basically learning to live reasonably well in a world of world of absence, essentially. And this requires and results in changing automatic expectations and thoughts and behaviors to fit this new world of absence. And when we do that, it really helps reduce the stress, and it also can promote growth. And it's something that we probably do very naturally if that process doesn't get derailed. And that's what we're going to talk about in a minute. But I just want to say that the how we learn to live in the world of absence is that we first of all have to accept that painful reality, the finality of the loss, the the reality and finality of the loss. I mean, most people are okay. I mean, they understand the reality, the occurrence of the loss, the sort of the reality of the loss, but its finality is hard to wrap your mind around when you first lose someone to death. And when we do, you know, the loss is permanent, so we're always going to have some kind of response to that loss, that we would call grief, some kind of wanting them back, some kind of missing them, that sort of thing. We don't lose our relationship with the person who died, because mostly, or importantly at least, our relationships with anyone close are primarily internalized even when they're alive, and they don't go away. That internalized representation, so to speak, doesn't disappear when they die, but it of course does change, and our lived experience of our relationship changes a lot as well. And whatever other changes, you know, have accompanied this particular loss, we need to deal with those. We need to accept those and adapt to the change world. And we use the concept of self-determination theory, um, put forward in the year 2000 um, by Edward Dici and Richard Ryan, to social psychologists who had done already a fair amount of work in this, but they posit that in order to thrive in our lives, we all need to have a sense of what they call autonomy, competence, and relatedness. And what they mean by autonomy is that we all have certain intrinsic interests and core values, and we need to be doing things in our life, maybe not everything, but we need to be doing things in our life that align with those in order to have possibilities for purpose and meaning and joy and satisfaction. We also need that sense of competence and agency, and we need the sense of belonging and mattering, which is what they mean by relatedness. And that's what and also, you know, the promise of satisfying relationships. And importantly, bereavement, loss of someone close, tends to undermine all of those. So we have to kind of rebuild those, restore those, as part of the process of learning to live with the loss. And we know that it can be facilitated by certain kinds of self-care, and support from others are important, and also importantly by balancing our confrontation with the reality of the loss. So balancing the emotional pain and respite from that pain, balancing how much we share with others and how much we just deal with privately. Most people need to find their own balance between, most people need both of those, as well as just being with others and being alone. And then also in the amount of time we spend recalling the past and the amount of time we spend envisioning the future. And I would say that well, we have an unpublished study that we did with a number of years ago, which showed that people with prolonged grief disorder are great at recalling the past. I mean, I think if you think about it, it's not surprising, but they're very good at recalling the past. They like to recall the past with the person who died. They like to think about it. They often do that in kind of a dissociative way, where they sort of daydream about the person, but they like to do that, and they're good at it, better than bereaved people who don't have prolonged grief. But they're not good at all at envisioning anything positive in the future. The future tends to look very bleak to them. So those are things that but being able to sort of get into more of a balance is one of the things that helps. So arguably, periods of defensive exclusion are actually needed. I think Bowlby talks about this, is that you really need to have bouts of grief interspersed with moratoria, is the way he puts it. He says that our minds naturally do this, and that's a really good thing, because when we're confronting the reality, that's when the attachment activation gets very strong and all that goes with it. And and so it's kind of too much to be just persistent. So we need to actually be able to kind of set it aside, either mentally set it aside, some mentally, some physically, um, and allow that activation of the exploration to at least pop up a little bit, to at least start to make itself felt. And so, and that's how we get to acceptance of the reality and restoring well-being. So the problem is for prolonged grief disorder is that this can be derailed or stalled. And it mostly happens when the defensive exclusion responses play too big a role. And these are primarily actually imagining alternative scenarios, maybe disbelief in and protest. Though the disbelief, the protest is not too uncommon also, but the disbelief is something that is kind of implicit, and it's more of a feeling. But then avoiding reminders of the loss and social distancing. And there's a Bowlby quote here that he emphasizes the fact that these are common manifestations of defensive exclusion that occur in almost all grieving people. But what distinguishes them from people who have problems, what he calls pathological versions of them, are the length of time during which they persist and the extent to which they influence mental functioning. And I would say the extent to which they're used really as the primary way of coping with the loss. And in addition, sometimes those sort of natural and probably implicitly motivated and automatic separation anxiety, caregiver ineffectiveness, and exploration inhibition that we talked about a few minutes ago, sometimes they're just so strong they won't let go. And so they also, when that happens, it's much harder to move forward. So they can also stall or stop the process of moving forward. So what this looks like clinically is a set of ways of people typically engage in dysfunctional or maladaptive thinking, in ineffective emotion regulation, other ways of emotion regulation aside from avoidance, in the overuse of the avoidance behaviors, so avoidance behaviors, and ineffective social support. So that's what we're going to try to, this is one of the things we're going to importantly target in a treatment, right? So I just want to summarize by saying again that prolonged grief disorder, we don't think of it as a completely different way of grieving, but it occurs because we're not able to adapt to the loss. And when we're not able to adapt to the loss, then what we get is continuation of that pervasive, intense grief beyond the time it's expected by oneself, but also everyone around us, to basically find a kind of quieter place. So what we're going to do in the treatment again is to try to remove those impediments or derailers and facilitate the learning process. So I'm going to turn to that, and we've done this by breaking the learning process down into what we call healing milestones, and we we have identified 6 of them, which when we address these 6, we're focusing on that restoration side, on the loss side, and then at the end on both. So accepting grief is kind of at the center of this. And it is at the center of what many grief counselors who work with people at all times, and anybody who wants help with grief, often this is where they work. And it is a really important piece of this process. But so just to say a little bit about learning to live with the loss, we know that learning is a multi-channel process. We sometimes think of it as just ways to change our thinking, but it really is more than that. So we're going to think about ways that people can experientially learn as well as cognitively learn. So we're going to help help the people with PGD to learn ways to understand and think about their loss a little differently, but also provide opportunities to experience the loss in a different way. And and that's kind of our goal. So we're going to use psychoeducation very heavily in this treatment, and also a range of psychotherapy techniques in order to change the cognitions. So we do use cognitive therapy techniques. We don't build it into to the manual, so to speak, but we sort of invite therapists to use whatever techniques they like to use to change cognitions, because there are a lot of great therapists out there who aren't cognitive therapists and they still change cognition. So we do that, and we use then a series of activities to promote the experiential learning. And these are the activities. Basically, grief monitoring we use pretty much for everything, but it's the core one to help people understand and accept their grief. We have a procedure from motivational interviewing that we call aspirational goals. We do a session with a visitor. I'm going to tell you briefly about all of these, and then we'll wrap this up and hopefully have a little bit of time for questions. So we're also going to encourage the use of these natural facilitators, and we're going to, as I said, try to identify and resolve the impediments to adapting as we're working our way through these different experiential activities. So active listening is at the center of this treatment, because we know that grievers, everybody needs to be heard, but people who are experiencing intense grief especially need us to listen to them, and to be present in listening, and to kind of share their pain. And but we know that even this kind of transformative listening isn't enough, so that's why we actually do more, as I was telling you. So we want want them to understand grief in the way that I was describing it to you before, that it's a stress response and a separation response, which is the form that love takes after someone dies. So grief monitoring, we're going to work with grief monitoring to help people, and also psychoeducation, of course, but to help people see their grief as a natural response to loss, to let it wax and wane naturally, which it will do. Even in someone with prolonged grief disorder, it does in the course of a day, doesn't stay at a 10 level, grief level 10 all day long. And we explain a little bit about how loss activates our natural feelings of separation concerns and caregiver ineffectiveness, and shuts down our natural desire to go out and do things in the world. And then, we help people, again, monitoring. There's some common impediments to watch for. We also use this as an opportunity to work a little bit with grief-related emotions, because they come up at times when the grief levels are very high. And this is the way we do it. This is our old-fashioned way. This was a paper sheet. We now do this of course, digitally. You can do it in a lot of ways, but the idea is it's a little different than some of the other mood and anxiety monitoring that we do. But in this, what we do is we ask people to just spend a few minutes at the end of the day to think back over the day, and identify one time when their grief was at its highest level, and rate it on a scale of 1 to 10, and then make a short note about what was happening at that time. Do the same thing with the lowest grief, what was happening at that time, and then just take a big step back and make a judgment about the overall level for the day, as low, medium, or high. And you can put a number on that or not. When we review this, we just pick one of the days that it was one time when it was at its highest, and ask the person to talk a little more about what was happening at that time. And usually almost always there's something then to discuss, which we do for only about 5 minutes in this treatment, because we then go on to something else, which in session 2, we start discussing what we call aspirational goals work, which is a particular procedure that helps people to think about a big long-term, well, first of all, to identify what are their core interests and values, things that are really important to them, and then to identify kind of activities that they could do to um, to link with those interests and or values, and then to plan a long-term project, which we do not try to encourage them to complete during the course of this treatment, which is 16 weeks long, um, but rather to start to work on it and to get however far they can, and then to continue it afterwards. We try to help them strengthen relationships by encouraging them to bring a significant other to to a session. We usually do this in session 3, and we use it to help the others, because what's usually happened with someone with prolonged grief disorder is that everyone around them is kind of very discouraged and disappointed and frustrated, and treating them with varying levels of distancing and or even harsh criticism, and that doesn't help anything, of course. And so we want to try to reverse that process, and with at least one person, and bring them in and sort of do the same kind of general psychoeducation we've been talking about, and then talk a little bit about um, the positive sides of their relationship with this person, which is generally not hard to do at all, because there are people waiting in the wings like this, and they just don't know what to do anymore. And then we try to have some discussion about how they can be helpful as well. Then we move to what we call imaginal revisiting, and this was derived directly from prolonged exposure for PTSD. And NAFOA was a consultant to our earliest studies, and really helped with this, but we ended up kind of modifying it some. We can talk more about it maybe, or you can learn more about it anyway in our there's lots of ways to learn more about this treatment, so this is really just a tasting menu. But we do this basically a 15-minute version of what we call imaginal revisiting, where we ask people to tell the story of the first learning of the death, but they do it for 15 minutes. Then we reflect on it for another 15 minutes or 10 minutes, because it's 10 minutes and 10 minutes. And then we ask them to set it aside and to plan a rewarding activity. And then we move to what we call situational revisiting, again from PE, because this is really a version of in vivo exposure, which interestingly, Richard Bryant has also used in his group treatment. He's done a group treatment that really tracks similarly to this one. It's not a version of prolonged grief treatment per se, but it is very similar treatment. And he just published a paper where they looked at the influence of avoidance and relieving avoidance on outcomes in grief compared to PTSD, and they are different. So even though the procedure is similar, it's really almost certainly doing something different. And lastly, we return to the idea of restoring a sense of connection to the person who died. And we do this with a series of really simple memories questionnaires that we give them, and then a very powerful imaginal exercise, which is inviting them to have an imaginal conversation with the person who died. And that generally is quite effective, but much more so when it's done at the end of treatment rather than the beginning. So just to briefly show you the results of this, we did 3 NIMH-funded randomized controlled trials, always comparing this treatment to a really good treatment for depression. The IPT in 2 of the studies, citalopram in the 3rd, and IPT was administered and overseen by experts, Ellen Frank in the first one, and Kathleen Clockerty in the second one. So this is our 4-site study, which we did in New York also with Chip Reynolds in Pittsburgh, Naomi Simon in Boston at the time, and Sid Zizuk in San Diego. And we basically found that we did not find a difference between outcomes with citalopram and placebo when administered without what we then called complicated grief treatment. But more surprisingly, we did think we would see that difference. So that was not what we predicted. And we also thought we would see a difference when we combined it with the psychotherapy, and we did not. However, when we looked at depression symptoms, we did see a difference in outcome with when it was combined with when citalopram was combined with what we now call PGT, it was significantly more effective in relieving depression symptoms. And depression is often quite often comorbid with PGD. So these are the takeaways. Maybe without going through them, you have a copy of these slides in a PDF format. And so I think we should try to answer a few questions. I will be happy to try to answer a few questions.
Thank you so much. I think this has been super enlightening, and thank you to all of our attendees for being here. We do have a question that came in. Um, the question is, some programs suggest grief occurs with other losses beside death. Does PGD only relate to death? I know you touched upon kind of environmental aspects a little bit. Could you go further on the other aspects?
Sure. I mean, absolutely. I mean, grief is really a reaction. It's our response to to any meaningful loss. I mean, that's I think very clear. I also think that the brain is parsimonious, and the attachment system, or the close relationship system, whatever. I mean, the attachment system again has a lot of empirical support for it, is so important to human life. I mean, we're basically social animals. And so I think it's probably functioning in some similar way, but maybe not exactly the same. But it's definitely the case that you can see these symptoms in after any meaningful loss. And we have seen them after all kinds of losses. You cannot, though, right now, at least diagnose PGD, at least not using ICD-11 or DSM-5 for anything other than the loss of someone close. So that's, I think, going to probably change over time. And I think, I think that some version of what I just showed you, or the treatments, actually what I didn't, sorry, I forgot my last slide. You can look at it if you want to learn more about this, we have a lot of training. We focus primarily on training. We are continuing to do some research at our center, but we focus a lot on training, and we have online training programs, fully online, self-guided tutorial that we call PGT Web, as well as a whole bunch of other ways of learning this treatment if you want. So Sasha, was that the only question?
The follow-up question, which you immediately answered, was, is there a training manual or
Okay.
for
I guess
so
yeah.
it's almost like you saw it. We did have a question about using PGT for adolescents, ages 14 to 18 particularly. Is it
Yeah.
appropriate for the age group?
Great question. And I basically don't know the answer because I mean, we don't have data about this. We do have a few anecdotes. I mean, people have used it for adolescents, and we at least had one example that was quite successful, but it hasn't been studied in adolescents at this point.
Okay, that makes sense. To be determined, right?
To be determined, yes.
And we did have a request of, do you have the citation for Richard Bryant's article about this treatment in a group format?
I do, but I'll probably have to send it. It's very recent. It's a 2023 paper. I don't.
Oh, someone just popped it right in. So for
Okay.
the person who answered the question, just go ahead and look. I'm gonna pop that in the chat for you. Which is not going, so that's fun.
Yeah.
And thank you to the person who popped it in the chat. Uh, and would you recommend anything different for complicated losses, like losing a loved one to suicide?
We do have data on. Yeah, that's another important question, because we do have data specifically on suicide. It's a paper published by Sid Zizuk in the Journal of Clinical Psychiatry maybe 2011, 12, I can't remember. No, it wasn't that. It was more recent than that, like 2018 or 19, something like that. But I think you can find that. Maybe someone can find that, but I can also send it to you, Sasha, and you can send it out later. But
Yeah, of course.
we and we initially in starting this work, I think like most people thought, well, it's going to be different. What we're going to have to do something different if the person who died was a child compared to a spouse or a parent or someone else. We're going to have to do something different if the death was by suicide or homicide or even accidents, sort of violent death compared to if it's a more natural death or illness related, predicted, prepared for death, that kind of thing. And I mean, there are a number of other kinds of facets that you might think, characteristics of the person or the death that you might think would require different treatment. We've always looked for moderators. First of all, we've always treated a range of people. Also, the time since the death has varied in our studies. It's been on average, it's been about 2 years afterwards, or in one study, 2 years, in another study, 4 years after the death. None of it moderates the response to this treatment, and at least we haven't been able to find it. It may, I mean, we've treated overall over 600 individuals, but still that's a relatively small number to be able to identify moderators. So maybe we just haven't been able to find them, but we haven't so far. And our therapists who use this do use it for all different deaths. And in particular, suicide, the suicide response was pretty much the same
Mm,
um, as the response to natural death. And also another point sort of related to that is that if we did the Davidson trauma scale, we administered the Davidson trauma scale to all of our participants in the most recent, in the large multi-site study. And Peter Na published a paper about that in 2019 or 2020. And what we found is that PTSD symptoms criterion level, using the DTS as the cut score on the DTS, criterion level symptoms were quite prevalent. Actually, they were, I think, something like 83% of the group met criterion level symptoms for PTSD, even though most of them were not bereaved in a violent way.
mm,
And so those symptoms are very prevalent, and they did respond to PGT treatment, similarly to the PGD symptoms.
mm. And kind of in the similar vein, do you think about how cultural adaptations can be used for this treatment?
Yeah, I mean, actually, that's a really great question. It's one of the things that's been on our mind very much recently. We've been working a lot with the Black community in Harlem,
Mm,
and a postdoc fellow in one of our longtime clinical affiliates together just ran a group in a setting which is a kind of mental health clinic connected to a Black Baptist church in Harlem. And they did this in a group form, and they did it um, with just kind of making cultural adaptations along the way. And it appears to be working. They don't have they've looked at their outcome data, meaning literally looked at it, and it looks good, but they haven't analyzed it yet. So we don't have all the data from that yet. But I think you can. Part of why I present this the way I do is because if you have the concepts here, that we do certain kinds of experiential exercises, we do certain kinds of cognitive work with people, psychoeducation. You can vary how you do all of that. If you have the basic idea that what you have to do is release I would say it as facilitate and the sort of natural adaptive process, including helping people accept the reality of the loss and also find a way to kind of honor themselves and restore their own capacity to thrive and feel connected in the world and feel competent and able to contribute and all of that. if you work on both of those kinds of things and use what makes sense culturally and change what doesn't, I think that should be, we've gotten a lot of kind of anecdotal feedback in our training that kind of thing is being done. So we don't have a lot of outcome data for it, but people seem to think it works.
Okay. Thank you so much. We're right at 3 o'clock. Dr.
Okay.
Shear, thank you so much for sharing this treatment information today. And thank you to all of our attendees. If anyone has any questions, I welcome you to reach out to webinars@adaa.org. If you are not yet a member, we invite you to become a member to attend sessions like this complimentary. Dr. Shear, thank you.
Thank you so much, Sasha, and thanks to everyone who participated today. And it's a pleasure to be here. Thanks for having me.
Have a great day.
Thanks.